Vinay.
Can we start?
I think we are live, so we can start. I think.
Yes, Ravi.
Hello, good afternoon. I'm Dr. Ravi Keralkar, arthroscopy and joint replacement surgeon at Sai Shri Hospital. Welcome to the episode 3 of this Sai Shri webinar series, where we are trying to cover common orthopedic ailments, how to diagnose them, how to treat them, and most importantly, how to prevent them. In the last two episodes, in the first, we tried to cover osteoarthritis and its treatment. In the last episode, we tried to cover common ligament injuries in the knee and their treatment. Today, we are covering a most common topic that we discuss in routine orthopedic consultation, that is osteoporosis in joints and neck pain and back pain. हम जब भी हॉस्पिटल में जाते हैं तो हमारे ऑर्थोपेडिक सर्जन्स पेशेंट को बोलते हैं कि आपकी हड्डियां कमजोर हो गई है, ऑस्टियोपोरोटिक है. तो ये ऑस्टियोपोरोसिस है क्या, इसे कैसे डायग्नोज करते हैं और इसे कैसे ट्रीट किया जाता है, इसके बारे में हम आज जानकारी लेंगे. ऑस्टियोपोरोसिस, उसके इम्प्लीकेशंस इन जॉइंट डिसीजेस, उसका रिलेशन नेक पेन, बैक पेन, इन सब के बारे में आज के वेबिनार से एपिसोड में हम लोग जानकारी लेंगे. हमारे की नोट स्पीकर famous orthopedic surgeon Dr. Neeraj Adkar, who is chief robotic joint replacement surgeon and director of Sai Shri Hospital. He was there with us in the previous two episodes as well. Joining today is my dear friend Dr. Ketan Deshpande. He is orthopedic spine surgeon. He completed his post-graduation from Pune itself and then did his spine fellowship from Dinanath Mangeshkar Hospital. To which he added qualifications with minimally invasive endoscopic spine surgery fellowship from South Korea. I'm glad to say that he has the maximum number of unilateral biportal endoscopy spine surgery cases to date in India. He will be guiding us through neck pain and back pain, and then we will have a physio session with our own physiotherapist, Dr. Ruben George. He did his physiotherapy bachelor's from Pune, and he aspires to become masters in sports rehabilitation. So now I will hand over to Dr. Neeraj Adkar, and I'll request him to start with his presentation. Over to you, sir.
Thanks, Ravi. I'll start sharing my screen. We will
Yes,
I'll try to cut down on other aspects like arthritis and joint replacement, and we'll talk at length regarding osteoporosis.
yes, sir.
Can everyone see this now?
Yes, we can see, sir.
And I'll try to cover it in English as well as in Marathi or Hindi. That anyone has any questions, do let us know. Joint pain. Whenever we talk about joint pain, knee joint is most commonly affected. Knee joint, as all of us know, it is made up of femur and tibia, that is thigh bone and shin bone, and patella, that is kneecap. Meniscus is a C-shaped structure inside joint, which acts as a shock absorber. But as you can see in this video, whenever there is injury to meniscus, it gets displaced in the center of the joint and it starts giving locking sensation. Previously, we used to trim it out, but nowadays we rip. Can rest of you please put it on mute, your speakers?
Yes.
microphones. Yeah. And so meniscus, we used to trim it out earlier, but nowadays we try and repair it arthroscopically, which is done through 5 mm portal, as you can see in this video. But since we are not going to talk at length regarding joint elements, maybe sometime during next webinar, we can cover it in detail. But this is a time-tested procedure where we are able to save the meniscus, and within 24 hours, person can go home. Ligament injuries, again, are routinely seen in knee joint and other joints as well. But knee, it is more commonly seen, and you can see in this video, the joint is completely unstable. But even though the joint is unstable, x-ray would be normal, because ligaments are a soft structure which we cannot see on x-ray. This is the picture of the torn ligament on your uh, left and left side, and right side is reconstructed ligament. So all these structures are soft structure which we cannot see on x-ray. So you sustain injury to the joint, and just because x-ray is normal, that doesn't mean all other structures inside joint are normal. So this is a video of articular cartilage. Okay, cartilage is a soft structure which is responsible for smooth or frictionless movement. Top video, left side, is a normal cartilage, and bottom video is a worn out cartilage. So when this cartilage goes off, bone starts rubbing against each other, and this process of cartilage wearing out is called as osteoarthritis. So typically x-ray would look like this on your right hand side, what x-ray you are seeing, where the gap between two bones is completely reduced. The initial phase we can treat with PRP or some injections, and but advanced stage where you need some operative like knee replacement. Since that's not the topic for today's discussion, I'm going to skip a couple of slides here. So this patient, this is before operation and this is after operation video. Complete transformation of the patient is possible after this surgery. Complete correction of the deformity is possible. So this is how knee x-rays were before the operation. There was complete bowing of the legs, and after operation, complete straight knees you can see here. This is before operation, and same patient after operation. This patient, in fact, ignored suggestion for the operation and sustained fracture of the bone, and we had to replace the join and as well as fix the fracture, and same patient 3 months down the line and fracture healed satisfactorily. Mobile bearing replacement, where the insert moves and it gives good range of movement after the operation, and complete flexion of the knee is possible and gives near normal feel. This patient had bilateral osteoarthritis, and immediate next day after the procedure, uh, he had almost 90-degree flexion after the operation, and same patient around 2 weeks, 12 to 14 days after the operation. Sai Shri successfully did bilateral uncemented knee replacement in India. That was the first uncemented both knees at same sitting were done in India 2 years back, and she's doing exceedingly well. We do have option of opulent or gold knee where these implants last long. One of our patients successfully, she was bedridden completely before the operation, and she successfully completed Narmada Parikrama after the procedure, and she's leading absolutely normal life. Placement where just one compartment is involved, and this we can do with robo assisted, and we do have that facility at Sai Shri. So this is a small animated video. This is how the robo works. So the preoperative movement, the so I'll pause the video here, as all of you can see that this is the screen, is called as a planning stage, planning screen, and where we can plan how the implant is going to sit, and how minor adjustment in the implant placement, also how it will affect post-operative range of movement. So before taking any bone cut, we can really see virtually how that will affect our end result after the surgery. And it is like cross checking your own surgery before putting the implant in, and that really gives good results. So once we plan the surgery, the pink portion you see here, that much cartilage, we are supposed to take it out. And once that is done, that turns into white. And as you can see, it is turned into white. That means our resection is complete and optimum, and that is ready for implantation. Similarly, bone and this. So once the resection is done, this is how it looks like. And this is a partial knee replacement. When deformity is more, where all compartments are involved, we can't offer a partial knee, but total knee replacement is required. And this patient came from Kenya, and she was absolutely bedridden. This is second day after the surgery, and this is 15th day after the surgery. Same, another patient aged around 75, before operation and after operation. We'll skip his feedback video. Now coming to muscle sparing TKR, muscle sparing replacement, where we preserve muscles, not only muscles, but the ligaments, and where you get excellent and speedy recovery after the procedure. So this patient at the time of suture removal, he was able to walk without any support and had excellent result. Another patient before operation and after operation, complete correction of the deformity. Another patient where you get complete correction of the deformity, and it not only just changes the joint but transforms patient completely. She's a relatively young lady, rheumatoid arthritis. This is before operation, very, very painful joints, and same lady after the operation. Extreme deformity pre-op and post-op, and same video, same patient leading a normal life. This is how she used to walk before operation, and this is after operation. So let's just go through the robotic technique here for total knee replacement in short, in brief. Like partial knee, complete mapping of the knee joint is done. And as we discussed for the partial knee, here for total knee, again, complete planning of the surgery is done before actual bone trimming or cartilage trimming, and that gives excellent result. And a couple of cases of hip joint arthritis here, and this patient was absolutely bedridden. Both hip joints were affected. The hip replacement was done using large femoral head, and this is how the result is. The bedridden patient, around 4 weeks after the surgery, after undergoing both hip replacement, is leading a normal life. And as you can see here, staircase climbing or day-to-day activities is absolutely comfortable for him, and complete pain-free joint. And
Excuse me, sir.
another patient, yes.
I'm sorry to interrupt you, but I think there is some problem with the link. The people are not able to join the uh, previously mentioned link, so people are not able to join. They are calling us on landline that this is the problem. It should be get rectified within 5 minutes, I guess.
Okay, should we stop,
I
or
think
should
we
we
should wait. I think we should wait.
because there are a couple of other people, those who are logged in.
Oh, yes.
So I'll just finish the arthritis component, and then by the time if
It,
people join, then they can listen to
yes.
osteoporosis part of the
I
presentation.
think that should be good. I think. Yes.
Oh. So this patient had both hips were affected, and this is how he used to walk before operation, and this is after operation. And complete transformation. Same patient where he was unable to do his day-to-day activities, and he's able to ride a motorbike and doing a normal activity. Another patient, he's from Africa, and hip arthritis, and after undergoing procedure 15 days he could fly back. We'll just keep this video, and maybe this is the last slide in the joint section. And a 100-year-old lady we operated for total hip replacement after failed first surgery where she was operated somewhere else, and she's leading a normal life. She's now 103 and absolutely leading a normal life. And this video was taken just 3 weeks post surgery. Okay, I think we can wait and for osteoporosis. So whenever you allow me, I can start my
Yes,
presentation for
once I get,
osteoporosis.
yes, sir, I guess once I get the confirmation, I will hand over to you again. I'll just check.
The problem is can we start now?
Sir, I think the participants are increasing, so we are good to go, I think.
We should start because those who are logged
Yes,
in, it is not good for them. No? They are logged in on
yes,
time.
yes,
It is our technical issue. So we should
yes,
not
sir,
be wasting other people time.
yes, sir.
So osteoporosis, as is defined, is a skeletal disorder characterized by compromised bone strength. In short, there is a quantitative loss in the bone, and it is also called as brittle bone. I mean, in WHO, according to World Health Organization, it is reduced bone mass per unit volume of bone with normal ratio of mineral to matrix. In simple word, it is not a qualitative loss, it is a quantitative loss. So for example, in 2020 you have say 100% bone stock. In 2025 you will have say 95% bone stock. So what it predisposes a person to sustain a fracture even after a trivial injuries, minor trauma. So around 30% females, they over 50, they will suffer a fracture due to osteoporosis, and 20% males. And it increases as age advances, this number goes up. And it affects hip bones, more commonly spine, wrist bone. So these are most common location sites for osteoporotic fracture. And in males, in fact, in India, hip fracture incidence in males is equal in females and males in India. And Indian males are more prone to develop osteoporotic fracture as compared to Western population. And as you can see in this slide, around 5 lakh spine fracture, 3 lakh hip fracture, 2 lakh wrist fracture, 3 lakh other bone fracture, they are due to osteoporosis. And this number is increasing every year. And as life expectancy is going up, and that's why the osteoporosis related fractures are also going up. And as you can see in that last point, by the age of 90, 1/3 of women and 70% of uh, males, they would have sustained hip fracture. So it is very important to prevent osteoporosis. So let's understand why osteoporosis happens. As all of us know, uh, the 10% of bone stock is replaced every year, the call through this cycle. So osteoblasts, there are three types of cells in bone. Osteoblasts, which are responsible for new bone formation. Osteoclasts, they take out the fatigue bone. And osteocytes are the neutral bone cells, which can get transformed into osteoblast or clast. So this cycle goes on continuously, and whenever there is more resorption of the bone, it leads to osteoporosis. There are various hormones which are responsible, and they affect the bone strength, and most common is vitamin D. See, one of the study in Mumbai conducted by KM Hospital, and they found out the 85% Mumbai population, they had vitamin D deficiency. So it is routinely seen, and it really affects our bone health. Along with vitamin D, parathormone, calcitonin, these various hormones, they have direct influence on bone strength. As I was explaining a couple of slides earlier, this bone remodeling cycle. So whenever there is more resorption, it leads to osteoporosis. So, and less bone formation. So we need to check on both the fronts. We need to increase bone formation. We need to restrict bone resorption. That's how we can treat severe osteoporosis. It can be classified into primary and secondary. Primary is involutional or idiopathic, where exact cause is unknown and more or less it is related to age. But secondary, it could be because of hormonal imbalance, some drugs like steroid, in malignancy and prolonged immobilization, or in persons with sedentary lifestyle, they are prone to develop osteoporosis. So postmenopausal osteoporosis is one of the routinely seen, commonly seen osteoporosis, and it is due to the hormonal changes in the body. And a woman who suppose attains menopause around 45, 47, uh, next 5 years after menopause are extremely crucial, and that's where the 50-60% bone loss happens. And that's where aggressive treatment for osteoporosis prevention is required. And as you can see, the steep decline in bone mass happens during that age group. And if we treat patients aggressively during that phase, it really gives good long-term result. So as bone density goes down, chances of fracture goes up. So risk factor for osteoporosis, it more and family history of osteoporosis, smoking, and can you hear me?
Yes, sir, but there was a break in your voice earlier.
Yes.
Now we can.
Now, yes.
Yes, yes.
Okay. And low calcium intake, inadequate physical activity, and steroid use. Clinically, person would have backache, bone pains, body ache. So backache is most common, and Dr. Ketan Deshpande is going to brief us regarding back pain and neck pain in his presentation, and various other causes of backache and neck pain other than osteoporosis. And see, if osteoporosis is neglected over the time, what happens? There will be bowing of vertebral column, and as you can see in this picture, it leads to bowing and is mainly because of osteoporosis, where your vertebral column is not able to transfer the weight, and because of the less strength, and it leads to bowing. And this is how it appears in typically elderly person with bowed vertebral column. And we safely conclude this as part of aging, but it is primarily due to osteoporosis. So osteoporosis we can diagnose with DEXA scan, bone mineral density, and this is how it is done. And then we get report about T score, Z score, and typically the T score should be more than minus 1. So if it is less than that, then it is concluded as osteoporosis. This tool, FRAC score, is developed by WHO to assess the fracture risk, and I'm I'll explain you on this chart. So, and this is country specific. Unfortunately, it is still not available in India. And so, woman in UK, 65-year-old, she doesn't have rheumatoid arthritis, as you can see on left upper corner, no steroid use, and there is no history of pre-or fracture. Then there are around 8% chances probability of she sustaining a fracture in next 10 years. But similarly, woman aged 65, she has rheumatoid arthritis. She's on steroid for a treatment of rheumatoid arthritis. There is a history of fracture. Then she's likely to have 35% chances of sustaining fracture in next 10 years. So prevention is by achieving good peak bone mass. So peak bone mass is a maximum strength in your skeleton, which you attain by say 20 to 23 age, 20 to 23. I will repeat. And then after that, you start that bone strength starts going down. So if you have peak bone mass, if you have good strength in your 20s, your strength, bone strength in 60s and 70s is going to remain good. So it is very necessary, essential for youngsters to participate in various sports activities, regular exercise to achieve this peak bone mass. So regular exercise is must, balanced diet, nutrition is important, and checkup. So diet, you should have good protein rich diet that really helps not just the calcium, but protein is equally important for good maintaining good bone stock. So vitamin D supplement is helpful. Keep your weight under check, but you should not do dieting, because that is not good for your health. Nowadays, that fad is dieting, but actually it doesn't help, and it really affects your bone strength. But that doesn't mean you allow your weight to cross and go beyond limits, and need to keep it under check. So you should avoid salt. So if you take too much of salt in your diet, that's not good for your bone, and calcium is washed out from the bones. And popular drink like Coke, Pepsi, they are not good for your health. It affects your bone strength. Caffeine or smoking should be avoided. If you smoke, just smoke will remain and you will disappear. So quit smoking as soon as possible. As we discussed, peak bone mass you achieve before age of 30, and you must strengthen your bones, and that's how you can prevent fracture. But if you have osteoporosis, you can start calcium vitamin D supplement under medical supervision. And hormone replacement therapy is indicated in very few patients, but it has to be done under supervision. Bisphosphonates we routinely use along with calcium vitamin D. Calcitonin nasal spray if osteoporosis is slightly more. and injections like parathormone and other agents in severe osteoporosis, they are indicated. So, friends, treatment for osteoporosis is regular exercise and good balanced diet. But along with that, we must aim at fracture prevention. So avoid slippery surface. If your osteoporosis not just affects bones, but it affects muscle tone as well. So maintaining body balance is sometimes becomes difficult in osteoporotic patients. So they should not hesitate by using a walking stick. There should be proper illumination. There was a study published in British Medical Journal where they mentioned that elderly people, senior citizens, they get up at night and their vision is impaired, and they start searching for specs, and then they sustain injury and sustain a fracture. So they, suggested that senior citizens, especially, they should, the space for their specs should be at a appropriate place where they can access it during the midnight as well. Proper illumination is necessary in senior citizens bedroom, and hip protectors are nowadays available where if you sustain some injury, we can still avoid or prevent fracture. So there is no substitute to regular exercise, and absolutely necessary to maintain good muscle and bone strength. So in short, prevention is better than cure. And if you have any question, do not hesitate to ask me. Thank you very much. Thanks for your patient listening.
Thank you so much, sir. It was a very informative session. There are few questions for our panelists, but I would like to tell our viewers that question and answer session will be after the presentation of all the panelists. Uh, Now I'll hand over to Dr. Ketan, who will be guiding us through neck pain and back pain in osteoporosis. Over to you, Ketan.
Just give me a minute. I'll stop. Yeah.
Thank you, Ravi. I hope my screen is visible to everybody. After that, after the talk by Dr. Adkar sir about osteoporosis in general, my talk is very specific about the neck and the back pain part of the osteoporosis. So before we get back to the main topic, we should first understand what is the concept of pain generator. So pain generator is something like a structure which is the primary cause of the pain. So pain per se is not a disease, but pain is something that is telling you that there's something underlying, there's some problem with the either the soft tissue or the bone or any other anatomical structure, and it just wants to attract your attention. So every time the pain is not a bad thing because it is telling you that something is wrong here and you need to be attentive to this part. As far as neck and back are concerned, the pain can arise from either muscles, it can be because of osteoporosis, it can be because of osteoarthritis, it can be slip disc, there can be compressive pathologies like spinal stenosis or osteoporotic vertebral compression fracture, or there may be some severe conditions like infections and neoplasms that can lead to pain generation. So let's have a look at all these pain generations in detail. Let's start with the most common thing, that's the muscles and ligament sprain. If you ask any person that even whether they had an episode of neck pain or a back pain in their lifetime, they'll definitely answer will be yes, because this is very common and all of us have experienced this thing, especially because of prolonged straining. So straining, some amount of stretching is good. Every trainer that you go to or every gym that you go to will be telling you that you should do proper amount of stretching before you start doing a proper weightlifting and stuff like that. But prolonged training, continuous training, that's more than 10 minutes, 15 minutes, half an hour, hours together, that is never good for a muscle. So prolonged training, nowadays in this post COVID era, people have started working from homes. Majority of the IT people are working from home, and for their office they might have a good chair with good back support, they might have an ergonomic sitting posture, but when they're working for long hours sitting at their home, it's definitely very difficult to maintain that posture for a very long time without those proper ergonomic equipments. So prolonged straining is the most common cause of muscles. Prolonged straining of those muscles and ligament is the most common cause of neck and back pain. The second point is mechanical pressure. If at all there is some pressure, that may be in the form of a swelling, that may be in the form of an outgrowth, or even some injury that leads to bleeding inside the muscles and cause mechanical pressure on the muscles, that can lead to pain. Third, and the most commonly seen in our OPD practice, is vitamin B12 and vitamin D3 deficiency. Vitamin D3 is a mediator of calcium. So even if you have ample amount of calcium in your body, but if you are lacking in vitamin D, that calcium cannot be utilized by the muscles. So you have good amount of calcium in your body and bones, but your muscles are still lethargic, because the mediator or the catalyst, that is vitamin D, vitamin D3, is essential for that calcium to be utilized by the muscles and not to cause any soreness in the muscles. And the last one is the injury. So whenever a patient with muscles or ligament causing back pain or neck pain comes to us, the basic treatment is, uh, ideally you should be changing the posture frequently. So if you are sitting for 8 to 10 hours a day, if your work schedule is for 8 to 10 hours a day, you should ideally be changing your posture every 45 to 50 minutes. For this, what you can do is simple things: get up from your position, walk around for a couple of minutes, again come back and sit at the same position. A light massage definitely helps, because what happens is, when you're prolonged straining these muscles, the muscle fibers, they get stretched out, and along with that, the blood vessels, those are supplying the muscles and providing the muscles with oxygen and other essential nutrients, they also get stretched out, and the muscle lacks these essential nutrients. So when you're doing a light massage, even over a sore muscle, it stimulates good amount of blood flow to that muscles, and increased blood flow means increased nutrients and increased oxygen, and that is why you feel better. Same is applicable when you apply heat to that affected muscle. When you apply heat, there is vasodilatation means the blood vessels, they open out, they dilate, their diameters increase, and the blood flow to that particular muscles increases. This is one of the most common question that is asked in our OPD: is hot fermentation better or cold fermentation better? The simple answer is, if there is any injury where you're suspecting that there is bleeding inside, at that point you don't want more and more bleeding to come. So in case of injuries, always cold application is better, because you don't want more blood flow to come in. Otherwise, when you want a sore muscle, when you want to treat a sore muscle, when you have back pain and neck pain, that is not because of injury, heat is always better. The second most one more common thing that you can utilize is strapping that particular muscle and immobilizing it. Just like when you have a bone fracture, we put a slab, we put a cast, we put a maybe a brace just to immobilize that particular fragment. Similarly, in case of muscles and ligaments, strapping definitely helps. The next point is osteoarthritis. Sir has very well described in detail the points regarding osteoarthritis. I'll just cover it up regarding spine. It's the inflammation. Osteoarthritis is just the inflammation of the bones and the joint surfaces. So in this picture, you can see that the picture on the left side is a healthy spine, and the picture on the right side is osteoarthritic spine. It's degeneration which occurs, which is age related, and it occurs more commonly in the elderly patients. There are certain forms of arthritis that can be detected on blood test, which include rheumatoid arthritis, gout, which is the increase in serum uric acid, and ankylosing spondylitis. So basically, the surfaces that are supposed to rub against each other, giving us mobility and not cause any friction, those surfaces get eroded, and those surfaces start becoming degenerated. More and more movement causes more and more friction, and it leads to inflammation, and then it leads to pain. There are two specific joints as far as the spinal column is concerned. One is the facet joint, and second is the sacroiliac joint. Facet joint is the joint that holds two vertebrae together, and sacroiliac joint is the joint between the tailbone and the hip bone. So these are specific joints that are very commonly affected. Any kind of unequal loading of the body weight leads to damaging the facet joints, or leads to arthritis of the sacroiliac joints. As far as the treatment part is concerned, The basic protocol is, first is the pain management, second is to facilitate joint lubrication. So we have to make sure that we have to catch this disease early, and we before the joint surfaces are completely eroded, and we have to ensure that the joint is well lubricated. Lubrication can be naturally, or we can have some substitutes which can be injected inside those joints in the form of facet joint injections or sacroiliac joint injections, and the friction between the two joint surfaces can be controlled. Uh, if the patient is presenting late, then we have to do some amount of damage control, wherein if one of the facet joint is getting arthritic, and it is bound to cause loading of the upper or the lower facet joints. And what we need to do is, we have to immobilize that particular segment, and to prevent the unequal loading of the other facet joints. And surgical intervention in the form of either joint replacement or fusion surgery is the last option. As far as osteoporosis is concerned, you can see in this picture that the first bone is showing normal density and mass, and the second bone is showing the loss of normal density or loss of bone mineral density, leading to osteoporosis. So it what the bone density when the bone density becomes less, that's what leads to weakening of the bones. It causes fatigue and stiffness. And sir has already mentioned about the treatment part, which includes diet, exercises, medicines, and hormone replacement therapies. Now let's come to some specific conditions, which includes vertebral compression fractures. These are extremely common. We see these kinds of patients day in and day out, and these patients do not have any injury of any history of major injury. It's just a trivial trauma, or sometimes it's just bending over or getting up from sitting position, and then they hear a click in their back. These are typically common in postmenopausal females, which come to us with this type of presentation, and they are prone for delayed healing. They can be associated with neurodeficit, or there can be no neurodeficit. There can be only back pain present in these kinds of patients. So if you can concentrate on the picture on the right side, this vertebra, or this vertebra, they are more or less similar in shape. They are square to rectangle or square in shape. You can see that their margins can be very easily pointed out, and more or less similar, lying on top of each other. But if you look at this fragment, this is a compression fracture, wherein the vertebra that was supposed to be a square shape with the opposite sides parallel to each other has completely collapsed. You can see that there is a white shadow inside that particular fragment, which indicates that there is some amount of bleeding or some fluid collection inside that vertebral column. So you imagine a structure like a tall building, which is like 30 floors building, and a segment in between starts to wobble around. There's obviously a possibility of everything that's on top of it collapsing. So these type of fractures, they need to be well immobilized. So you have to put those patients in cast. You have to make sure that the patient is immobilized. You have to make sure that you give adequate amount of pain control to these patients. And usually these fractures per se, they have an underlying pathology. They are secondary to either osteoporosis, or they can be secondary to some other form of diseases that can lead to weakening of the bones. In extreme cases where 3 or 4 weeks of good supportive treatment, pain control is not able to result into fracture healing, in those cases surgical intervention becomes a must. The surgery that we do in these kinds of patients, wherein the vertebra is just compressed but not migrated, is not leading to any neurological deficit, is just causing back pain and difficulty in moving. What we do is called vertebroplasty. So under local anesthesia, what we do is we put a needle under live X-ray control directly into the fractured fragment. We inject some dye, and we confirm that that particular space is contained, and then we inject liquid cement, that's vertebroplasty bone cement, which is compatible with the bone. So what this cement does is, when it goes inside it, the setting time of this cement is very quick. Within 12 to 15 minutes, the cement completely sets in, and the abnormal movement that is happening across the fractured fragment is completely stopped by the setting of this cement. We check the integrity of the cavity in both front and the side view on a live X-ray, which is available inside the operation theater, and then we can start mobilize the patient as early as 2 to 3 hours after the procedure. Since the procedure is done under local anesthesia, there is no risk of general anesthesia or any associated complications like heart diseases, diabetes, or old age. They can easily undergo these kinds of procedure. The next most common thing that we find nowadays is slip disc or sciatica. What exactly is a slip disc? So two vertebrae in the spine, they have a soft cushioning structure in between them. This is be called as a disc. This disc has two parts. One is the outer shell and which gives the integrity of which maintains the integrity of the disc, and the central part is the soft cushioning that allows some amount of movement across this joint. So when the outer shell ruptures and the inner soft portion comes out, we call it as a slip disc. So if the disc is coming out, naturally it is occupying some space which was previously occupied by some neural structure, and that leads to irritation of the root that is going either in the leg or in the hand. So if you have a slip disc in the neck region, that will lead to neck pain along with, and the pain will be traveling into either of the arms. If the disc is on the right side, the pain will travel from the neck into the arm right up to the hand. If the slip disc is occurring in the lower part, in the lumbar region, the pain will start from the lower back, and then it will travel either on right side or onto the left side. This type of pain is typically increased on stretching. So if you try to stretch out your arm when you have a slip disc in your neck region, you will have more pain. And when you put your arm like this, or when you fold your arm, or you go into a curl position like a baby, the pain typically is reducing. So same is true with the leg also. If the compression of that particular nerve root is more, then it is usually associated with tingling or numbness like sensation either in the hand or in the leg. If the compression is very significant, that is, if the compression is more than 50 to 60%, then the affected region starts to become numb, or the muscles that are supplied by that particular nerve root, they start to become weak. The treatment part, usually these type of disorders, they are seen more commonly in the younger population. So it is usually a self-limiting diseases. By usually I mean more than 75 to 80% of the cases you do not need a surgical intervention. What you need is a proper diagnosis in the form of MRI, and then some amount of immobilization either in the form of a corset or a belt or a neck collar, and some rest will definitely your body has that capability to take care of the problem on its own. The role of physiotherapy is very important in early stages of slip disc, wherein you have to make sure that you have to maintain a posture that will not cause any increased pressure onto the disc. So an already ruptured disc, you don't want to put too much of pressure on top of it, so that the symptoms and the severity of the disease might increase. Third is pain control. Pain control can be in the form of either painkillers or muscle relaxants. Strapping of the particular region also helps. When all these treatments fail, we have to go forward and do a surgery. So we usually give, as per our protocol, we usually give 4 to 6 weeks of conservative treatment. And if there is no pain relief, or if there is ongoing or progressive neurodeficit or weakness in the leg or the hand muscles, then we have to go for surgery. Initially, what we do is we do try some transforaminal or epidural nerve root blocks, wherein we go put in a needle, inject some medicines that will reduce the size of the disc herniation and relieve the pressure of the nerve roots. But even if that also fails, the surgery can be done in the form of an endoscopic surgery. So this is a small video that will show you how an endoscopic surgery is actually being performed. So this surgery is done under local anesthesia and some amount of sedation. Uh, Under local anesthesia, a needle is placed from the side portion of the back directly up to the spine. This needle is placed under live X-ray control, so that we know exactly where that needle tip is going. Once it reaches that particular disc fragment, we give some more amount of local anesthesia at that particular site. Then that needle is replaced with a guide wire, On top of that guide wire, we take a small incision. The incision is just 8 millimeters in diameter, so that's just smaller than a 1 centimeter. Then over the guide wire, we pass a cannula. This cannula is a blunt obturator, so there's no dissection or cutting of the muscles. It's just separating the muscles and going inside with small rotatory movement. On top of this cannula, on top of this obturator, we pass a cannula, and this cannula provides us a pathway, which is like a tunnel from the skin up to the disc fragment. Through this tunnel, the scope goes inside. Once the scope goes inside, the picture inside, it looks something like this. So if your needle placement is proper, you can just directly land on top of the disc fragment, and you just need to go in, use some forceps and take out those big chunks of a disc that is ruptured from its normal position. You can see that the nerve root is pulsating after the disc fragment comes out. And on table, the patient, because the patient is under local anesthesia, the patient himself or herself can tell you that the major part of the pain is gone now. So it's a very simple, straightforward procedure. Since it is done under local anesthesia, the patient can be mobilized as early as 1 or 2 hours after the procedure, and it's a daycare procedure, so the patient can go home on the same day. So you can see this patient, the left-sided video. You can see that she is one of the patient that had undergone a similar procedure. You can see that she had extreme pain, difficulty in walking. She was not able to stand up straight also before the surgery. Immediately after surgery, she was mobilized on the same evening, and this one is the post-operative video, and you can see that now she's walking straight. She's able to she doesn't need any support, and she has a pain-free walking. So this is the kind of result that you get with the endoscopic spine surgery. The next most important thing is canal stenosis, wherein the circumference of the spinal column itself is reduced and it's compromised, and it leads to generalized 360-degree compression of the spinal cord. If it occurs in the neck, there can be weakness in the hand muscles. If it occurs in the lower back, there will be weakness in the leg muscles. We have to grade the amount of spinal stenosis at the time of presentation, for which we need an MRI. In grading, if there is compression of the spinal cord, but if it is less than 50%, definitely can be conserved. If it is more than 50%, it becomes slightly difficult to conserve those patients, because they already have some amount of neurodeficit or weakness, and we have to opt for surgical options. The treatment protocol is physiotherapy, that's core strengthening, followed by epidural adhesinolysis, wherein if there is pressure on the nerve root but it's not more than 50%, we inject some medicines around the spinal column, and these medicines, they help in taking the pressure off the spinal column. We give them pain control, and the last option is in the form of surgical decompression. So this surgical decompression nowadays, which was done previously, which was done like an open surgery, nowadays can be done with puncture holes, wherein 1 or 2 holes are made in the back, and the procedure and the whole decompression can be completed. This procedure is called unilateral biportal endoscopy, or UBE. We all know that, like previously, all the surgeries, say for example, ACL ligament injury of the knee, the surgery had to be done with a larger skin incision, and an open surgery needed to be performed, which needed a lot of sutures and everything. Nowadays, the same surgery can be performed by making small holes, which many a times do not even require to be stitched. Just bandaging them is good enough. Similarly, in spine also the same technique can be used. This is the part where this is the actual inside view of the spinal column, and when you can see that the soft cotton-like structure that is coming out, that is the disc compressing the spinal cord. The white tubular thing that you see in the upper part of the video is the spinal column, and this the cotton-like structure that was compressing the spinal cord is the disc fragment which was compressing the spinal cord. So it's a very clear field and a magnified field. Since the scope has got a camera at the tip of it, you can very easily see a magnified view on the screen, and the surgery is performed. Once you remove the disc fragment, the surgery is over. So it's a very straightforward and a predictable surgery. The incision is, there are only two puncture holes. One of the incision is 5 millimeter and the second one is 1 centimeter. And the second picture that you see on the right side is the 1 month post-operative. You can hardly notice that there was any incision there. So the rehabilitation becomes very easy. The patient has very less pain post-operatively, and they can get back to their routine within 24 hours. So the take home message is, the pain that is arising either in the neck or the back is not a disease, but it's a symptom of an underlying disease. The most important part is we have to identify the pain generator. There can be multiple pathologies that can lead, that can cause neck pain and back pain. So we have to have a lot of differential diagnosis, have a proper clinical examination, blood work, X-rays and MRIs, and come to a proper diagnosis so that the treatment part becomes very easy. There is no alternative to good food, good posture, and good exercise, and regular health checkups are mandatory. Uh, Sitting is the new smoking. That's the theme of today, because most of the patients that are coming to us, they have these kinds of problems starting because they have chronic sitting. So we all know that smoking is injurious to health. It is very bad for our health. But sitting for prolonged hours of time is as bad as smoking, and we should always remember that. This year, the theme of World Spine Day is back on track, so it's very suitable as far as the post-COVID era is concerned. So I wish you all a very speedy recovery, and thank you so much.
Thank you, Ketan. It was a very, very nice, interesting presentation, especially for the back pain patients who fear for spine surgery. That unilateral biportal endoscopy was a very interesting revelation for all of us. Uh, we will now go to Ruben, who is our physiotherapist. He will show us some exercises and guide us through his tips on how to prevent osteoporosis. Ruben?
Thank you, Dr. Ravi. Am I audible?
Yes, yes, we can hear you.
Good evening to one and all. I'm here today so as to show you the way a physical therapist looks into a patient who has come to our clinic with osteoporosis. And I shall show you the basic management which we do so that any patient who comes with osteoporosis is easily dealt with, and we can get the patient back to the best functional outcome as soon as possible. I hope my screen is visible to all.
Yes.
So I'd like to start by saying the main role of a physiotherapist in a patient with osteoporosis. Now, sir has already mentioned that osteoporosis is loss of bone mineral density. It's commonly occurring in the age-old population, but we have seen nowadays that even the younger generation is quite commonly affected as well. So when a patient comes to us, we need to make sure that we prevent. As sir had mentioned earlier, prevention is better than cure. Educating a patient regarding this condition and telling them as to how these conditions can be prevented would be the best possible way to avoid such conditions from occurring in the future as well. And only the treatment part of it is only a subset of what we actually do. A physical therapist is also supposed to know and make any sort of lifestyle changes, any preventative strategies, and also making sure there is no history or any connection with the family which has led to this particular condition, so that we can inform them accordingly and such things do not occur in the future as well as in the coming generations. Sir has already gone through these. These are the basic signs and symptoms of osteoporosis. I shall not go into it. I'll just brush through it. And the main risk factors, which I shall be explaining today, is the patients whom we see. Now, the patients who come commonly to our clinic are patients with Colles fracture. That is basically a fracture of the forearm, the radius bone, and hip fractures. These are the most common fractures, patients who come with fractures, because osteoporosis, patients do not really recognize that they have osteoporosis unless they have a fracture. That is a very important thing. That's when even we doctors realize that the patient is suffering from osteoporosis when they come with a fracture. So these are the main factors. Gender, obviously, for some reasons, there has been a study which has shown that females are at a higher risk compared to males. I shall tell the reasons forward. Race, sir has mentioned, it's more common in Asians compared to blacks. And family history, age, as age progresses, because of the drop in their bone mineral density, there's a greater risk of falls and greater risk of fractures, which is why osteoporosis is extremely common in the elderly population. The main points I would like to focus on is the low body weight. Now, why the low body weight is extremely important is because people, for especially people who come to the clinic, or people with a higher fat mass, have a protective benefit, because in fat tissue there is conversion of two very important hormones called the androgen and estrogen. So there is conversion of androgen hormone to estrogen which occurs only in fat tissue, and that provides a protective benefit for those, and the risk of them developing osteoporosis is much lesser than those who have a less amount of build. So when a patient comes and he's very lean, or he or she is very lean in stature, we should always try to identify that that may be one of the reasons as to why a patient is having osteoporosis. Now, the reason why it is more common in females is because of loss of menstruation caused by anorexia nervosa. Anorexia nervosa is, simply put, excessive eating when a patient is very nervous due to loss of menstruation. Earlier, when menstruation takes place at an earlier age, like around 40 to 45 years of age, again, there is lack of the protective estrogen hormone, which is why females are more commonly affected by osteoporosis as compared to males. The second important thing is alcohol and smoking. We cannot emphasize this enough, because almost 80% of the patients who come to our clinic with osteoporosis have a history of alcohol and smoking. The reason why we tell them to immediately terminate this is because the metabolic products which are formed by tobacco, it reduces calcium formation, and it also causes breakdown of estrogen, which is the protective factor. So it is sort of a double attack. And the medicines which people take as estrogen pills, it's not enough to compensate for the loss of the bone mineral density, and it causes a major issue in them. And so terminating them, it comes to the physiotherapist to explain that terminating alcohol and smoking or any bad habits is extremely important. That would be the first, that would be the start of our treatment. Then another thing is inadequate calcium intake. Obviously, when there is no enough calcium in the body, as a result, there is reduced calcium formation, and because of the reduced amount of calcium in the body itself, there is depressed bone formation. As Adkar sir had mentioned in his slides earlier, osteoblasts, these are the cells which stimulate muscle growth. They do not act well, and because of that, the risk of osteoporosis is highly intensified. And the most important, which we talk about, is low physical activity and immobilization. When people with fractures are immobilized for a long period of time, immobilization leads to a lot of muscle weakness, balance loss, and incoordination. This is a major reason as to why osteoporosis occurs, especially in the elderly population, because when there is no exercise, there is no effect of gravity or any sort of mechanical forces which are acting on the joint. And because of these forces do not help the cells to stimulate excessive bone, and that is why there is reduced bone formation. This is mostly prevalent in the elderly population, as I said again, but now due to the sedentary lifestyle of the younger people and middle-aged people as well, this is growing to be a common concern amongst all medical professionals. So what we do as physical therapists is to educate the patient. Before we start treating them, obviously we need to educate them about the various risk factors like the ones I had already mentioned above. Medical and pharmaceutical management is done by our surgeons and our doctors. Pain management, including self-help techniques. Now, pain management, this is more self-help techniques is usually common in people with rib fractures, especially osteoporosis. In osteoporosis, rib fractures are extremely common as well. So we teach a lot of patients the process of splinting, which helps them in reducing pain to a great extent, which occurs even when they cough. The pain produced when coughing is also extremely high when a patient is when a patient is osteoporotic. Exercise, about which I'll be talking further. Nutritional information, that is basic information regarding how diet should be monitored, increased amount of calcium intake in their diet, and prevention of falls. This is more related to geriatrics because they are at a higher risk of fall as compared to the younger generation. Simple prevention strategies: when a patient comes to us with osteoporosis, we can tell them, like sir had mentioned before, the use of assistive aids while walking. A lot of elderly people have the confidence to walk on their own. They have a habit of walking for long periods of time. So we should tell them to use any form of support. It may be a spinal orthosis, or it may be as simple as a walker or a walking stick. That may be more than enough to deal with prevention of falls. They can also make a lot of changes at their homes, which may include application of handles, bars, especially in the bathrooms, proper illumination, making sure that switches are placed outside the bathroom so that they do not have a risk of fall once they enter inside, and if it is especially dark. And in the dark as well, as if they need to access something very easily, it should be in near access. There are other things as well, as such as floor management. They can make preventative floors or non-slippery surfaces, avoiding the use of rugs, or in order to climb stairs they can add a slight slope rather than climbing stairs, which also reduces the extent of fall. So when a patient comes with fracture post osteoporosis, there are a lot of things we do. First is we educate them about proper mobility and transfers. That is explaining them how to use a walker, how to shift from the bed to a walker, or how to properly bear their weight on each limb while they are walking. When a patient comes with pain, we deal with different types of pain. It can be either acute or it can be chronic. We usually use ice. As Dr. Ketan had mentioned earlier, any sort of injury which is acute is dealt with ice, and any sort of chronic injury, especially in the knee, is dealt with a heat therapy. It's also commonly used for the back. Electrotherapy, we have different modalities. Electrotherapy is basically stimulation of the pain fibers itself using the modalities we have, like interferential therapy or ultrasound in some cases. Interferential therapy basically stimulates the nerve fibers which carry pain, and because of that it blocks the pain signals which are reaching the brain, which is why it reduces pain to a great extent, and it really helps the patient a lot in the short term. Along with that, there are soft tissue techniques, there are spinal mobilization techniques we use, which can help them in ease of mobility and increases their range of motion. When we deal with exercises, there is a reason as to why we give extension exercises. Basically, the reason is because extension exercises have shown to improve posture and strength as compared to flexion based exercises. The reason why extension biased is, that is why even in our clinic we follow the protocol of giving more extension exercises such as bridging or any sort of yoga therapy like bhujangasana, what people usually do. These are extremely important exercises which can help such people. Now the long-term management of this was the short-term management, of course. Now we come to the long-term management. We start with resistance training. Now, as seen on the slide, strength of elderly people has improved using light wrist and ankle weights, and also elastic bands. Now these therabands what we use, it is shown that these high intensity and low repetition movements have had the most benefit, especially in postmenopausal women. It helps in developing bone growth. It stimulates the osteoblastic formation, which helps in improving their characteristics of the bone. It becomes a little more dense, and it becomes a little more strong. And any sort of weight bearing exercises, we follow the rule of slow, gradual, and controlled, because it has been shown that any slow, gradual, and controlled movements especially maximize muscle strength and maximize bone growth as well. As I said before, weight bearing exercises, the reason why they're important is the gravitational forces or any sort of mechanical forces which act on the joint. They stimulate the formation of osteoblasts, that is the bone producing joints in any, especially the knee or the ankle, and also for the hand. And we usually include all major muscle groups for that. I do have a video for it, but I shall just finish the presentation before then. Another important aspect is hydrotherapy, something which is being developed in India, especially for a long period of time, where people don't understand the importance of water. simple swimming activities or simple walking activities or cycling activities in water has proven to be of great benefit, because the main important thing is it improves cardiovascular fitness and muscle strength. And the reason being the principle of buoyancy. It counteracts the effects of gravity. So old people have a lot of benefit in hydrotherapy, and it has also shown a faster amount of functional outcome compared to those who are just sitting in the clinic and lifting weights or doing any sort of other activities. And the last part of it is aerobic exercise. Aerobic exercises are nothing but simply functioning your cardiovascular system by either walking, cycling. Now, the protocol given here, that cycling of 20 to 30 minutes for 4 to 5 days, it's been taken from the College of Sports Medicine in America. They have actually shown by proven research that any sort of cardiovascular activity like walking or low jogging, it helps to a very big extent, because it helps in the first thing is it improves bone formation, and it also resists the use of depression of the osteoclastic formation, that is any sort of activity which reduces bone growth. People who supplemented these aerobic exercises with weight training have always shown better results than those who are only performing other exercises alone. So I'd only like to say that whenever a patient comes to us excuse me. So whenever a patient comes to us in the clinic, the patients might come with knee pain, or a patient might come with a lot of wrist pain. So we never look at that particular joint per se. We always look at the patient as a whole. It is a holistic approach. And it's not only by the physiotherapist, a dietitian, a counselor, a surgeon, a doctor. Everybody is involved in the treatment of osteoporosis. And it is only when a person takes all the accounts and he kinds of involves it into his lifestyle, that is when he gets maximum benefit out of it. So thank you. If I would like to show the video, if it's available, just let me check. So I hope my video is being seen.
Yes, we can see your
Yeah.
screen now.
So this is basic resistance band training, which is being shown in the video. It can be performed by people of all age groups, and it's extremely easy to perform. These are basic exercises which we need not only do it in the clinic, it can be performed at home on a day-to-day basis as well. Simple exercises like tying it across your legs, trying to pull it up. It strengthens all major muscle groups, and it's extremely beneficial for people who are trying to improve their muscle strength, especially in geriatrics. These exercises which are being shown right now are especially important for the hip muscles, because hip muscles are one of the most commonly affected sites we have seen, and also it's seen that for involving all the major muscle groups of the lower limb gives maximum benefit. This video also shows some stretching exercises which helps, and these are what I said, the weight bearing exercises. These are weight bearing exercises where a person is kind of performing the extension movement. If you can see the video clearly, while they're getting up, the entire body chain is in an extension position. So this is a push form of exercise which we give in the clinic as well. It helps in the formation of bone very quickly, and it's a very beneficial exercise for people of all age groups. It's not only limited to the ones of the elderly population, it's very important for those even in the younger age groups. And wall push-ups. This involves the upper limb as well. And this is the basic protocol which we follow in this is the basic protocols which we follow in our clinic, and this gives the maximum benefit. So that's how I'd like to end my presentation. It's basically to see any patient whom we see should not be checked as with a joint pain per se. The patient should be looked as a complete person as a whole, and only by completely evaluating the patient will we know that there is a particular problem occurring, and if there's any changes which needs to be made in his or her lifestyle, it can be made. Thank you.
It's especially important for us. Walking, rolling past the road beds are
Thank you, Ruben. Thank you, Ruben. It was a nice presentation. We have some questions for our panelists. We have some questions for our panelists. Due to some time constraints, we will take a few of them. For all our viewers, if you have some questions, you can contact us on the address and all the numbers given on the screen. You will be seeing in a minute. Yes, that's the screen. You can get into contact with us with these numbers, email, or we have our website as well. So the questions are, I think this question is for Dr. Ketan. Dr. Namita wants to know, can a hemangioma lead to a back pain, and how should it be treated?
Hemangioma per se leading to back pain is quite rare. Most of the times hemangiomas are pretty benign structures. Hemangiomas are basically a bunch of blood vessels that are growing inside the vertebral bodies. Ideally we should watch them and rule out any other causes of back pain. If we notice that the hemangiomas are expansile, they are progressing over a period of time, then definitely yes, they are one of the differential diagnoses of back pain, but quite rare. As far as the treatment part is concerned, we usually what we do is as far as the treatment protocol is concerned, what we do is we try and take help of the interventional radiologists, where they can isolate the particular blood vessels that's supplying to the particular region or the particular vertebra. They coagulate it, and then what we can do is either inject some alcohol or we can inject cement inside that vertebra and give strength and stability to that particular vertebra, and that can take care of the pain part.
Parmeshwari wants to know how do you
Parmeshwari wants to know, how do you differentiate osteoporosis, fatigue, or back pain and hypothyroidism clinically?
Actually, these two diseases are, the diagnosis are based on the aging, because osteoporosis would be seen in elderly, and you would rarely see a hypothyroid patient attending at that age and without getting the particular diagnosis, because the patients will have associated symptoms right from brittleness of teeth, abnormal nails, overall fatigue, stunted growth, and all those symptoms which are very hard to miss in earlier period. And osteoporosis will always definitely be a disease of the elderly, unless a major endocrinological problem is involved, and simple blood test can tell you which is what.
Thank you, Ketan. I think we can conclude our meeting here. All our viewers can get in contact with us. We will be back on the 7th of next month with webinars specifically on common shoulder ailments. The points to covered will be frozen shoulder and rotator cuff injuries. See you then. Goodbye.